Well, greetings, Dr. Gyani and Dr. Alhawsawi. It's my pleasure that the three of us are speaking today. Really, the topic of the conversation is patient safety. Let's talk about saving lives. Dr. Gyani is a guest today. He is currently the Director General of the Association of Healthcare Providers in India. He has experience of over 5 decades in administration, R&D, and quality management. During his tenure as Secretary General of the Quality Council of India from 2003 to 2012, Dr. Gyani established the National Accreditation System for Healthcare, called NABH, for the first time during 2005-06 in India, and got it accredited by ISQA for standard as well as organization. His effort has laid foundation for patient safety, as NABH accreditation has been widely adopted by various government and private insurance schemes. Let me add something here, more personally. I have known Dr. Gyani for many years now. Formally, informally, he is known throughout the country and in that part of the region as the father of quality and safety movement. So welcome, Dr. Gyani. Let me start first by introducing myself and Dr. Alhawsawi. My name is Dr. Abha Agrawal. I'm currently serving as a Chief Medical Officer for a hospital on the west side of Chicago. But really, most important, my role as a practicing physician, as a healthcare leader, most importantly, my role is that of a patient advocate. And that's what this conversation is about. Dr. Alhawsawi.
Thank you, Dr. Agrawal. Good evening, Dr. Gyani and everyone. So my name is Abdulelah Alhawsawi. I'm a transplant and hepatobiliary surgeon, but I'm also someone who is, I call myself a patient safety advocate. I was the founding Director General of the Saudi Patient Safety Center in 2017. And took it to become a WHO collaborating center in 2020. And also during my time in the Saudi Patient Safety Center, we hosted the 4th Global Ministerial Summit on Patient Safety in Jeddah, as well as we introduced patient safety to the G20 agenda. I left my position at the Saudi Patient Safety Center towards the end of 2020, but I continued to be involved in patient safety both locally, regionally and globally. I'm part of the WHO steering committee for the World Patient Safety Day. But again, just to add to what Dr. Agrawal said, our goal of this conversation is to try to look at the local context of safety, and why is it that when we know what to do, that we're still having difficulties actually achieving zero harm. And so that's the goal, and it's a pleasure to have an eminent person like you, Dr. Gyani. And I think our goal is to hear throughout the globe a kind of from a local context what asking the same questions to get maybe similar or different answers. So this is where we want to take this forward. So again, thank you very much for your time.
Thank you, Dr. Alhawsawi. Dr. Gyani, to start with, please share with us a personal story, either related to you or someone you know, that will bring the human face to the patient safety and or health worker safety.
Yeah, if I go back in my career, there was a time in 1980s to 1990. This is precisely the time when India started working on quality in some measure. You see, what I have learned with my experience is that quality can be driven only when consumers are driving it. That means if it is supplier driven, that means no quality. It has to be consumer driven. And what I learned in my own experience, that healthcare supply or healthcare services were always in the short supply. Even today, they are in the short supply. So it was a very difficult task for us, to build the framework for healthcare quality. And that is, the turning point came when the parliament, this question was raised by some member that now that private healthcare is coming up in India and they are setting up the certain state-of-art hospital, and they are attracting the patient from Middle East, GCC countries, as far as even from USA. Some people were coming for, cardiac, procedure particularly, I am saying. So do you have any accreditation system? So, what I'm saying, that birth of accreditation or quality or patient safety was born in India due to pressure or the demand from the medical tourism, not from within. And somehow, people like me and my colleagues, we thought, okay, this is an opportunity, let us work on it. And we promoted accreditation as patient safety. And our slogan was, healthcare quality and patient safety are two sides of the same coin. So, because otherwise, there was a lot of, opposition when we started working on it, that you are building something for the foreigners. You are building something for the, people who are coming to India. That means there's nothing in it for us. And that is where, we brought this point. We linked it, that patient safety means saving the lives, the slogan which you have put actually. If you see my olden slides, this used to be the one, that the healthcare quality may cost, but the absence of healthcare quality may cost the lives. With that slogan, I think we picked up, and that was in year 2005.
Thank you. Dr. Alhawsawi.
Okay, thank you very much. So then, if we want to kind of dig and drill to the current situation in India, and India is a big country, lot of population. But if you were to kind of basically list the top three areas of harm in the Indian healthcare system, so if you were advising the current Minister of Health and trying to say that we need to have a national patient safety strategy, national patient safety plan for the following reasons, what would be the top three areas of preventable harm that you see through your expertise in the Indian healthcare system?
Okay. You see, I will go back again here, that in Government of India, because I have been serving with the Government of India for almost 30 years, there was a time that they sent some of us to UK for training on quality. That was actually overall quality, not particularly the healthcare quality. And I picked up the specialization there on the healthcare quality because I had the background on laboratory quality, before going to that. And when I came back, the Government of India established an Institute of Healthcare Quality with the German collaboration. And there they gave me the task of heading that institute. I think that helped me to build the capacity in terms of the healthcare professional, quality professional. Because I realized one thing, that we may talk of framework, but unless you have the people at the ground level who can take up this task across such a big country. So this 10 years time we spent on building the healthcare professionals, certifying them and making them available in the market. So to our pointed question to the government was, number one, build capacity through the certification of the healthcare professional, number one. Number two, then establish the framework for healthcare quality. And number three, most important was that government should be seen to be driving the healthcare quality. Because we mentioned in our paper that because consumers cannot drive, because there is a shortage of the healthcare supply. Whenever there is a shortage of supply, the supplier is the king. So we thought government through regulation, must, drive this quality. But let me also mention here the limitation of the government at that point of time. Government, because didn't want to bring a severe regulation, I will say, or strict regulation, because they didn't want to hamper private sector to come up. So they allowed, I don't want to use word mushrooming growth of smaller nursing home in the residential complexes or wherever they find, where they can set up a hospital without bothering so many safety consideration in the infrastructure in terms of resources. So, but I think so this is the way it went on. And only when we actually brought the accreditation in the standard, and then the government started utilizing our standard. Now, okay, if you have to work in the country, then you must have this accreditation system, and for which they made a simple rule. If you are accredited in the government insurance schemes, we will give you 15% more reimbursement. That worked as a magic. And so that was the beginning, I will say. Private insurance company came much later, but that is the government push we wanted, and we got it from the government.
And based on that, to carry on that point, from your experience, from the accredited hospitals, I'm sure part of that is to have a reporting system. Do you have a sense of, especially now that we're coming in with more telehealth, so do you have a sense of what would be the top 3, harm areas? Is it related to surgical issues? Is it related to diagnostic errors? Is it medication harm? I know it's difficult to have a national reporting system, but just from your expertise, if you were to kind of pick the top 3 areas, what would be those? Because I think strategically speaking, how to intervene and deal with them is going to be important.
Right, good question. You see, when actually we were launching this accreditation framework, I told you the year 2005 and 2006, and actually launch was in year 2006. I found in the hospital industry, the message went around that this is the job of the hospital administrator. And these are the administrators who have to actually establish this framework, drive the accreditation, face the assessment, face the audit, and things like that. Of course, some of the administrators were also doctors. But by and large, clinicians kept them away. And quickly we realized, that was precisely the year 2009, I remember, that we realized that only way to build quality and improve the patient safety is to involve clinician into the accreditation process. And for that, what we did was, all the assessor or surveyors, what we call, we made a rule that any assessor or surveyor program, we will take 70% people who are running clinician, practicing clinician. We promoted clinician to become the surveyors. And when they started surveying the hospital, they started seeing they started understanding the standard, applying them in the various scenario. When they went back to their own hospitals, they became our champions or the drivers. And the medication error, what you just now mentioned, was one of the hallmark of our standard. And so for example, surgical site infection became one of the critical area for evaluation in all the assessment. So these 4 or 5 clinical indicators, which we defined in our standard, in the first edition I'm talking, now of course we have got many indicators, but those 5 indicators started driving the clinician to work on these parameters, and then they realized the benefit out of it. So the trick of the trade, I will say, is that we started in the team of 3, we started sending minimum 1, most of the time 2 clinicians in the assessment. And today, if you ask me, we have got any number of super specialist doctors as our surveyors, and that only has improved the clinical outcomes in our country. And now the latest is that the National Health Authority, which is driving the world's biggest insurance scheme, biggest insurance scheme, I'm taking 40% of the Indian population. That means 500 million people. Can you imagine? Now that scheme is working on what Dr. Abha's is the pet subject is, that paying for the performance. They have started now defining paying for the performance model. In a year's time, whenever it comes, the patient feedback, clinical outcome based on those 5, and now they will be doing 10 indicators. And third one will be the managerial indicator to improve the efficiency of the hospital. Efficiency of the hospital also is one of the parameters which we should not forget, because affordability of the healthcare will come when we are able to deliver the healthcare at the affordable cost. And so in paying for the performance, we also want to bring this component, utilization of the equipment, utilization of the manpower, utilization of the space. So this model now is currently under development. I think that hopefully will change the whole scenario of safety and quality in our country.
Thank you, Dr. Gyani. This is great. I'm looking forward to pay for performance and its unintended consequences that we very well are familiar in the US, but let's move on. We often talk about To Err is Human as the landmark publication that started to change globally the consciousness of people about patient safety. Having said that, it has been almost over 20 years since the publication of To Err is Human. And just to quote some numbers, 5 people around the world are still dying every minute from medical harm. We know that at least 1 in 10 people who are hospitalized experience some medical harm during their hospitalization. We also know that the problem is even more sort of acute or more prevalent in low and middle income countries, although it's really everywhere. So that means even though we have been working diligently for over 20 years, the vision of zero harm is still, it still eludes us as a global patient safety quality community. So my question is, in your opinion and vast experience, what should be done to make the vision of zero harm a practical mindset for everyone in healthcare in India, including patients, families, health workers, policy makers, regulatory organizations, the government? Would love to hear your thoughts on that.
The clinical governance is a topic which is parallel to, you can say, accreditation system. But we talk about clinical governance mostly in the books. And I don't see, this word commonly being used. What we did in year 2012, I will say, 12, 13, 14, we started going around the top hospitals of our country, which were already accredited. And one of the trick of the trade was that each places, we started calling meeting. I used to go myself also. All specialty HODs, we will put them into one room. And we will debate for one full day. The simple model which we gave to them was that each HOD, once in 15 days, will call a meeting of all the fellow surgeons and physicians. And we gave them the checklist that these are the simple things, you please make a review. I must tell you, Dr. Abha, that India being shortage of the specialists, in the same department, let's say orthopedic, 3 orthopedics, what they are doing, orthopedicians are doing, other 3 are not knowing. They don't even interact because they are so busy in their own surgery, in their own OPD. They don't even talk to each other. They don't learn from each other. So this once in 15 days, all of them will come, share their experience, what procedures they did, what outcome they came, what were the problems. And that meeting, the diagnostic head will be sitting, concerned nurse executive of that particular department, she will be sitting, a facility manager will be sitting, And so they will deliberate and come out and include that the medical errors, the possible errors or these, whatever events which were happened in that, they will be reviewed. Let me tell you, in beginning, it was not easy. They were not sharing, but gradually, because it's their own department, nobody else is there. And then subsequently, after 1 year, we said, then once in a month, CEO like you will call all the HODs, and then he or she will ask them, okay, what has happened in your own department? What you expect from me to do to facilitate or the functioning to improve? I think this model, let me also be very frank here, has been working in very few hospitals. But this model of introspection within your own specialty, and you may call it clinical audit, follows from that only, but this is bringing little change in our systems.
The biggest thing, in your opinion, to bring the change of mindset, so everybody's thinking about Vision Zero Harm, is really introspection in a safer space where people feel comfortable sharing stories of harm and sharing solutions.
So you see, one more thing, I'll tell you how this mindset can be changed. Along with the HODs, the biggest another hurdle which I realized in my career now is that the CEOs, they are not able to link quality with the financial outcomes. You see, CEOs are more focused on the financial outcomes. That this, my EBITDA should be 25%, my EBITDA should be 30%. And if the EBITDA is going down to 15%, there's a hue and cry. They forget every other thing and they only focus. So the challenge now is, which actually is ongoing, by the way, nothing much has happened. The challenge is, if you are able to convince or make CEO understand that quality can bring you the economics or the financial gains, I can assure you things will change drastically. So to again come back to the same story, that the CEO linking financial gain with the quality, each HOD doing introspection in his own specialty. And of course, other thing is empowerment of the rest of the people is the side story, but these two are the main. If you can solve these two problems, I can assure you the quality scenario in that hospital will suddenly make a big quantum jump.
Can I push a little bit on this, Dr. Gyani, because I kind of know the healthcare system in India. The majority of healthcare in the country, even as of now, is delivered in small nursing homes, not in large, standardized, accredited hospitals. I'm talking about a 5-hospital nursing home, a 5-hospital, 10-hospital nursing home, 5-bed nursing home, 10-bed nursing home, 2-bed ICU, run by a family with kind of flying under the radar. There is no HOD, there's no clinical governance. They may or may not be accredited, but majority of the care is being delivered there. And therefore, the majority of harm might be happening there. How do we get the message to them?
Yeah. So let me give you the simple statistics of our country. I think you know it better. We have roughly 3,500 hospitals with a bed size of 100 and above. This is too small a number for a country of our size. These are the hospitals, you can call them as a tertiary care hospitals, only 3,500. Then we have got around 20,000 plus hospitals with a bed size of 30 to 100. Now for them, we started 4 years back a scheme called quality certification, one level below accreditation, where the standard is very small, very simple rather, and not much of the limitations when we are doing the assessment. At least to generate that feeling that there is something called certification. These are the indicators, and we then were able to convince government, the state level government. They also have certain schemes, insurance scheme for their citizens. And we have now been able to succeed that they have linked this certification and giving them 10% more incentive. And gradually now, so this is happening. Then I will tell you something more, which you are concerned and which also is my concern. 40,000 small nursing home below 30 bed. This is where I don't know whether we have been able to make much impact, because many times they are driven by husband, wife, single doctor, in the location, and they don't think of tomorrow. They only think of today, what is happening, So I think our challenge is going to reach out to them, and the government now is thinking of financing them. Instead of opening new hospital, the government is thinking how we upgrade them. And we have a method of, for example, Siemens, Philips, General Electric. We are trying to tell them, you establish the radiology center in a place where, let us say, there are 30 small nursing homes. Provide them these centralized services. Similarly, big diagnostic lab, automation, we established there. This is the way to reach out to this 40,000 smaller nursing home, which definitely remain the area of concern. And but I tell you, journey has started, I can tell you. If you are able to touch those 3,500 plus 20,000 hospitals, our half the battle is won. Remaining half is that down the line.
Thank you.
Dr. Gyani. So I think this is very timely. That takes me to the next question, which is either in those 3,500 hospitals or in any other smaller, healthcare facility. I think one thing that we can do a better job of the globe is to bring the patients and families to be empowered, so we help them to help themselves. So this is co-production, which, if we're defining safety, patient safety, as the absence of harm for every patient at all time and on every time and every place, it becomes mission impossible to do it only if from the private side or from the government side. I think if we empower patients and their families with the right tools, they will be very excited and enthusiastic to be part of the team and to help, contribute, even by, reporting whatever concerns or what have you. So from your perspective, what co-production tools or kind of patient and family strategies, the best ones that you've seen on the ground through your experience, that you think are impactful and helpful?
Yeah, it's a difficult question, and I really have no simple answer. As a quality professional, I absolutely am convinced that best quality can be driven when you empower the consumers. Consumers are the best people to drive quality, not payers, not government regulation. But this can happen. For example, these 3,500 hospitals are mostly in tier 1, tier 2 towns of India, where due to our promotion of quality, most of the consumers now are becoming aware about it. And in the accredited system, there is also a provision that they can make complaint directly to the accreditation body. So that environment is building up now. Our problem is some of the tier 2 and mostly tier 3 towns, where unfortunately shortage of specialists, we are not able to establish the tier 3 or a tertiary care hospital. Best is where we are managing with primary healthcare or some bit of secondary healthcare establishment. There it is little difficult to empower the consumers, or you can say we have not been able to educate them that you have right to demand healthcare quality or patient safety, which means 1, 2, 3, which means accreditation, which means monitoring their indicators, things like that. Because these hospitals are not even putting their indicators on the website. That I think we are talking of tomorrow, as far as India is concerned, for these tier 3 towns. But I absolutely emphasize with you There are consumer councils now coming up in big towns. They are meeting among themselves. For example, there is a central government health scheme where all serving central government people, judges, member of parliament, they all are there, and they have governmental run scheme, what we call central government health scheme. Now, these beneficiaries have formed their own consumer body. And this is very powerful body, which is putting, pressure on the hospital, which are providing central government health services rather. But as I said, this is a small portion of the 1.3 billion population of India. But beginning has been made, and I absolutely agree with you that this is the best way if we can really achieve that. Drive the quality through consumers.
Thank you.
Interestingly, Dr. Gyani, they could, in anywhere, I often think about this, especially being familiar. We can at least empower our consumers to talk to patients and nurses, doctors and nurses, to say, please wash your hands. That doesn't cost really anything, to put a sign at the bed, head of the bed of the patient, to say, please wash your hands. That alone would save probably thousands of lives in a country like India. But you are absolutely right about the challenges, of consumer empowerment in smaller cities. I think you have talked plenty about the linking financial incentives with the pay for performance, and even talking about, consumer councils, putting pressure on the government. Anything to add where quality and the finances should be linked? Any other innovations that you are thinking of in the country like India?
So, as I mentioned too, the only beginning which has been made is by the National Health Authority. This is a new body, by the way. It is not really integral part of the health ministry. It is little out of the health ministry and very empowered body. One of the tasks given to it is the National Digital Health Mission. This is a very ambitious program of India, and where they are making registry of doctors, clinic, nursing home, chemist shop, such a through using satellites and all that. So basically, this National Digital Health Mission is to make the healthcare technology driven, and so this National Health Authority. You see, you can't really, if the pay for performance model can only succeed when you have technology, because how will you really pick up the medical errors? It has to be automatically generated from the surgeon's table or from the diagnostic lab. So this model now they have started working. So that's why I told you, a year or two from now, this technology will be able to help us in really improving the clinical or health outcomes in our country.
It's a great point. How do you leverage technology?
Yes.
As Dr. Alhawsawi, you talk about at the macro level, not at the micro level at the bedside, at the macro level, to drive quality and safety. So great example. Thank you.
So speaking of technology, what about reporting systems? So we know from high reliability industries, one of the reasons they're safe is they have a very robust reporting culture that any potential failure in processes, not necessarily harm, and then they build learning systems on them. How common or engaged is reporting in India from your experience, especially in the hospitals that you mentioned that they're accredited?
Yeah. You see, we had a very special training program for our surveyors, because our problem was how to pick up, these medical errors when we are going to do the assessment. Now, because hospitals were not actually reporting, so we actually kept extra hours during our survey, and we trained batches after batches, and that these 5 clinical indicators, how you are going to pick up when you are going to a hospital. Now, this actually has started working, and now the hospitals by themselves, they keep the things ready and they are able to demonstrate to our surveyor. So this is precisely happening as far as fully accredited hospitals are concerned. In certified hospitals, which are lower level, we have still not been able to do it to that extent, but you can see that they will follow in time to come. So basically, I will say training of the surveyors is the key. And second is making hospital to do robust internal auditing. So in our surveying program, what we have done is we have given extra weightage now on the internal auditing system of the hospital. How they train their internal auditors, how at what frequency they do the audit, and how these audits are reflected during the management review. This is a key component which is actually making impact. So that means making hospitals realize that do it yourself rather than wait for the accreditation body assessors or surveyors to come. So these tricks are now helping us to really work.
Maybe also as a something to think about is to start having hospitals and regions educate the public about those KPIs. So when they go to the hospitals, they can ask, about KPIs. Some clinical units actually have publicly report the hand hygiene, compliance rate, etc. So I think this is something that could be interesting as an empowerment tool.
Is there any public reporting right now? Is there any public reporting?
I will need your help and Abha's help to really to do this, because I will be very frank on